Good evening, everyone, and a very warm welcome to the second session of Evidence to Decisions, a Journal Club initiative from Clinical Research Forum, FCPI. I'm Amartya Sriracha, co-lead of Clinical Research Forum, and I'll be moderating today's session. It gives me immense pleasure to introduce today's speaker, Dr. Akila Olas, a Doctor of Pharmacy graduate who brings her over 3 years of experience in clinical pharmacy from a large tertiary care center in India, working across critical care, infectious diseases, gastroenterology, as well as ambulatory care. What truly stands out is not just academic excellence, but real world impact. She's been actively involved in antimicrobial stewardship, audit and feedback initiatives, PKPD based dose optimizations. Interesting, right? She translated theory into bedside patient care. Beyond clinical practice, she has presented her research both in national and international platforms, including an abstract acceptance at an International Infectious Diseases Conference in the US. Currently, Dr. Akila is based in Australia, gaining exposure to international pharmacy practice. Today, she will be presenting DOTS randomized control trial, exploring Dalbavancin's role in complicated Staphylococcus aureus bacteremias and other infections. I encourage all the audience to type your questions in the chat box and do not miss the chance to contact and communicate with such an expert in the field. Without any delay, let's delve deep and hear from her. Over to you, Akila.
Thank you, Amrita. Good evening, everyone. So thank you, Amrita, for a wonderful introduction. Today, we will be discussing a critical appraisal of the DOTS randomized clinical trial, which evaluated the Dalbavancin versus standard intravenous therapy for the treatment of complicated Staphylococcus aureus bacteremia. So this presentation, which is a part of Clinical Research Forum, and coming to the first slides of this presentation. So why this topic matters. So when you look at the epidemiology of the SAB, like Staph aureus bacteremia, it's remained a major global health burden. So according to the CDC, that's Controlled Drug Disease, so there is a data from the United States which estimates more than 1 lakh cases in 2017, which is nearly 20,000 associated deaths, which is caused due to the SAB. So when you look at in the Indian perspective, the WHO surveillance data from 2023 show that the MRSA, which is the methicillin-resistant Staph aureus, accounts for more than half about, which is 53.6% of all Staph aureus bloodstream infections. So this highlights not only the scale of disease, but also the growing challenge of antimicrobial resistance. So what is the current guidelines for this SAB infections? So current treatment guidelines emphasize the prolonged intravenous therapy for Staph aureus bacteremia. So when you look at the IDSA guideline, which is a standard guidelines for all of the infectious disease, which is provided by the Infectious Disease Society of America. So for MSSA or MRSA, when you look at the MRSA treatment, the first line agent will be the vancomycin, which is based on the weight-based dosage, which is 15 to 20 mg per kg dose IV every 8 to 12 hours for 6 weeks. And some healthcare system is following the addition of gentamicin or rifampicin to with vancomycin, but it's not routinely recommended. Only the vancomycin alone for 6 weeks are allocated for the MRSA. Critical MRSA treatment. And the second line agents, other agents is daptomycin. This also weight-based therapy, that's 6 mg per kg per dose IV once a daily for 6 weeks. And some experts are recommending higher dose like 8 to 10 mg in some major cases. For MSSA, like methicillin sensitive strains, their ideas are recommending beta lactams such as cefazolin or sometimes it's anti-staphylococcal penicillins like nafcillin or oxacillin, which is for the 2 weeks IV antibiotics if the patient is not allergic to penicillins. So these are the standard therapies, current standard therapies for the SAB infections. So what is the main objective, main theory of this DOTS trial? This is what we are going to discuss in this session. Why we need to look for the alternatives. So while effective, so standard therapy has a practical limitations. So prolonged IV treatment often means that like a PIC lines, there is a lines which is specifically intended for the administration of this IV antibiotics in especially in patients who are in critical care. They may be undergoing long-term IV access and extended hospitalized patients or at or each associated with the catheter-related complication. That's IV problems. And sometimes it's adherence issues. The patient may not or may adherent to the IV therapies. And there is an increased healthcare cost. So these challenges prompted interest in long-acting agents that could safely amplify this therapy. So Dalbavancin is a long-acting agent with strong MSSA and MRSA activity. So this will provide a sustained therapeutic levels with the 2 weekly doses. When you compare to the standard IV therapy, that's 6 weeks therapy. So early studies were promising but inconsistent, highlighting the need for a rigorous randomized trial. So Dalbavancin, which is offer weekly dosing, which means fewer lines, like there is a shortage of shorter duration of the IV lines access, shorter hospital stay. So this study was designed to evaluate the efficacy and safety of Dalbavancin compared with the standard therapy for completion of treatment in the complicated SAB infections. So this is the main objective or rationale of these DOTS trial. So when you coming to what was unknown, why this Dalbavancin is very important. So the central unanswered question was, can Dalbavancin provide comparable outcome to standard therapy while reducing the burden of prolonged IV access? So can convenience to be achieved without compromising the safety or efficiency? So this is the unknown questions which is arising from this DOTS trial. So coming to the trial design, how the trial was performed. This is the main part of a trial. So DOTS was a multi-center randomized control trial conducted across 22 cities in the United States and 1 site in Canada. It followed a superiority design and enrolled hospitalized adults with complicated SAB bacteremia. So there is an inclusion criteria that adults is more than or equal to 18 years and hospitalized the patient with the complicated SAB, including right-sided endocarditis patient, and achieved blood culture clearance and fever resolution, received 72 hours to 10 days of initial antibiotic before randomization, and exclude patients are CNS like central nervous system infection, left-sided endocarditis, retained infected prosthetic material, severe immunocompromised patients, polymicrobial bacteremia, hepatic insufficiency patients, and pregnancy or breastfeeding patients. So it is a multicentric, what I earlier said, and we compared with the standard IV therapy, and which was a cefazolin or Staphylococcus penicillin for MSSA, or vancomycin or daptomycin for MRSA. And the participants were randomly assigned in a ratio of 1:1. They were received either Dalbavancin 1500 mg intravenously on day 1 and day 8. So what the trial says. So what is the primary outcome of the trial, which is called the DOR, that's desirability of outcome ranking. So in the DOTS randomized clinical trial, the primary outcome was the desirability of outcome ranking at the day 70. The primary outcome was assessed using this DOR. This composite outcome integrates the clinical cure, complication, safety events, mortality, and health-related quality of life. The DOR approach was chosen here for the better reflect the real-world clinical decision-making rather than a single binary endpoint. Here, why the DOR matters. Unlike the traditional endpoints, DOR balances the both benefit and harm. So it allows the clinician to judge whether treatment provides an overall desirable outcome or considering not just a cure, but safety and patient-centered outcomes also. So this is the key baseline characteristics of the DOTS trial. So here, the baseline characteristic between the Dalbavancin and the standard therapy groups were generally well balanced. This reduces the likelihood of selection bias, and which is strengthen the internal validity. So there is a MSSA. So the value is 67%. When it goes to the MRSA, it is 33%. And DM patients was 46%, CKD 25%. And the source of infections like soft tissue infection, which is 35%. Endovascular infection was 22.5%. So this one, which is explaining about the clinical outcomes of Dalbavancin across the key infection scenarios in the DOTS trial. So this is comparing with the different types of infections with the Dalbavancin. So first one is a complicated SAB. So outcome when you compare with the Dalbavancin and standard therapy, which is not superior, and the result DOR probability was 47.7%, and clinical success is 73% versus 72%. So what was the clinical interpretation in this complicated SAB was Dalbavancin is effective, but not better than the standard IV therapy. When you compare the MRSA, there is a similar efficacy between the MRSA and the MSSA, and comparable DOR and clinical success. And Dalbavancin works equally in MRSA, both in MSSA also. And the patient who got the endovascular infection, especially in the right-sided patients, comparable outcomes with the standard and the Dalbavancin. There is no major differences between the subgroups, and it can be considered in selected cases after the clearance. So it should be considerable in some cases. So clinical outcomes here were assessed across different infection scenarios. So no major subgroup demonstrate a clear superiority of Dalbavancin over the standard therapy. This is also some of the infections like skin and pulmonary. They're also showed as similar outcomes. But what I earlier said, like there is no major subgroup demonstrate a clear superiority of Dalbavancin over the standard IV therapy. Coming to the enrollment to analysis, a total of 200 participants were randomized in this trial. Exclusions included like polymicrobial infections, left side endocarditis, CNS infections, retained prosthetic material, and prolonged prior antibiotic exposure. By day 70, 167 participants had evaluable efficacy outcomes with losses mainly due to the death or a withdrawal of consent. There is a lost follow-up in this trial because of the death before the assessment and the withdrawal of the consent. So what's the study strength and potential biases? So we are comparing the strengths and the potential biases of this DOTS trial. So the key strengths are including it's a multi-centered randomized control trial, and it's a use of the patient-centered composite outcome. There is a follow-up up to 180 days. And when you look into the limitation, it's an open label. So performance was biased. Many exclusions was there, CNS infections, left side endocarditis, and some of the other infection. And trials stopped earlier, so reduced power. Dose subjective interpretation, not powered for non-inferiority, and there is a small sample size, like 200 participants only was there. So however, it is important to note that this was a superiority trial, not a non-inferiority study. So similar outcomes cannot be interpreted as equivalence. Coming to the inferential statistic overview, because the trial was powered for superiority, failure to demonstrate superiority does not mean Dalbavancin is equivalent. So this distinction is critical when translating result into the clinical practice. So this is the overview of the overview of this DOTS trial when you come back to the data. So what was the key observations in this DOTS trial? The first question will arise. It's like, does this apply to Indian or bad practice? So in the Indian context, so the applicability depends on the drug availability. So Dalbavancin was not easily available. OPAT infrastructure, microbiology patterns, the MRSA prevalence. When you compare to the US or Canada or Indian, the strains of the MRSA would be different, and access to follow-up and patient affordability. Every patient can't afford the cost of the Dalbavancin because it's a highly costly drug, and Dalbavancin may be most feasible for selected patients, like example stable or cleared bacteremia patients, high risk from long-term IV lines rather than a routine use. And Dalbavancin may be suitable for carefully selected patients, like high risk from prolonged IV access. And the second question is, does it apply where Dalbavancin cost is high? So in the DOTS trial, the Dalbavancin was not superior to the standard therapy by the primary DOR outcome. So although it met the non-inferiority for clinical efficacy at day 70 article, so therefore, when the drug cost is high, routine substitution is difficult to justify purely on the efficacy grounds. So use may still be cost justifiable in selected patients where avoiding the prolonged IV access. The third will be, does it apply to prosthetic material? Absolutely not. Because individuals with the retained prosthetic materials were excluded from this study. So we can't use Dalbavancin in a prosthetic material, a patient who got the prosthetic material infections. So what is the main points from this trial was, it's like Dalbavancin, it's not a universal replacement for the standard therapy in complicated Staph aureus bacteremia. Its role is best reserved for selected or stabilized patient, where simplifying therapy offers meaningful clinical or logistical benefit. So that was the main topic, main thing or main take-home message in this DOTS trial. So thank you everyone for your attention, and yeah, over to Akshay.
Thank you. Thank you, Dr. Akila, for the clear and insightful presentation. Thank you for walking us through the DROT trial and also helping us think critically about what data actually means for clinical pharmacists. You really highlighted that dalbavancin may not necessarily replace the standard therapy, but it is only a meaningful alternative for patients who are stabilized and also in areas where OPAT is feasible. Your approach and acknowledging both the strengths and limitations exactly reflects the kind of critical thinking we aim to promote in the evidence-based directions journal club. Thank you for providing your knowledge with all our delegates today. We have a couple of questions. So the trial assumes that a fixed dosing of dalbavancin, but
Yeah.
in real life settings, this wouldn't be possible. As a clinical pharmacist, how would you handle the situation? I mean, weight-based dosings can be possible, renal adjustment, and of course, we are talking about critical illness, or even though if they are stabilized, there could be other PKPD factors affecting. How would we modify the dosing?
So you're asking about the dalbavancin dosage?
Yeah.
Yeah. So if I'm working in a critical care patients, there is a lot of things you need to know when before you're going to prescribe dalbavancin. The first thing is what I earlier said. It's a IV access. When you compare to the standard IV therapy, dalbavancin in critical care patients is feasible because shorter IV access. And the second thing is absorption thing, because the IV formula, it is readily absorbable. And the second thing is like, third thing is like the third thing is like the dilution pattern. How are you going to dilute? Because the dalbavancin is a new drug, there is a shortage of guidelines. How are you going to dilute? How many times? And how long you will infuse that drug. There is no much guidelines for dalbavancin. There is no standard guidelines for dalbavancin in critical care patient, how we can administer the dalbavancin. There is only the dosage is there, but no administration protocol for the dalbavancin in critically ill patients. And yeah, what is the strain of the MRSA in the, if you are working in an Indian scenario, the strains are different. So how the strains, how this dalbavancin is will work for the Indian Indian occurred MRSA strains, how it is effective, because this trial was only performed in Canada and US based MRSA and MSSA strains. So we would not know how it will going to effective for the Indian people. And the second and the other thing is like how the dialysis dose would be, it is dialysable or not. We would not know about the dialysable capacity of this drug, and how often we need to go if the patient is dialysing, if the patient is going for a continuous dialysing patient. So that would be a major question mark for if you're using in a critically ill patient. And yeah, like ECMO, if the patient is going for the ECMO also, it's very questionable thing. Yeah, these are the challenges if you are using in ICU patients, because there is no standard guidelines for dalbavancin.
Yeah, that pretty much is the need for more data and need for more
Yeah.
studies to perform before we use them and actually at the bedside. And these are the challenges that we face on a day-to-day basis as clinical pharmacists. Apart from this, we have another question about the OPAT in Indian settings. From clinical pharmacist standpoint, because OPAT is not that standardized or structured in our settings, what would you recommend for clinical pharmacists to do so that they can optimize OPAT?
For the Dalbavancin.
Or any OPAT in general, from the
Mm-hmm.
stewardship perspective, what can a clinical pharmacist do to structurally improve and then monitor the patients? How do we uh, improve OPAT in general in our settings?
I think it is like a patient. OPAT means it's like what administration of intravenous antibiotic therapy to
In
clinically
the
stable.
outpatient setting,
Yeah,
yeah.
outpatient setting. So when
The
you
follow-ups gets
yeah,
difficult.
uh,
Monitoring
follow up
of
is very
adverse effects
difficult.
get difficult,
Yeah,
yeah.
follow-up is very difficult in when you look at the Indian hospital, I mean Indian healthcare system. There is a lack of out follow-up are there. When you compare to the international things, we got because I'm working here, we got a systematic way of follow-upping the patient. We got the very computerized systems to monitor the patients. So that's the main drawback of the OPAT in the Indian healthcare systems. And there is some shortage of skilled of nursing facilities, like a local infrastructure and resources. There is a shortage of that. That's a major thing I can tell you. So these has to be improved. So as a clinical pharmacist, we can do much better OPAT for the patient, because we are more into the medication and more into patient counseling. So we can guide them how to do that, and we can guide other healthcare professionals also how to improve these things.
True. Counseling plays a major role. I totally
Yeah.
agree with that. So yeah, I cannot see any more questions, but if you guys have any other questions, you can reach out to Akila or on our FCPI website. Having said that, on the behalf of Clinical Research Forum, I sincerely thank you, Akila, for sharing your time, expertise, and perspectives with us. It was a pleasure to have you as a speaker. And thank you so much to all the delegates who are available here for having listened to this so patiently. And yeah, have a great evening, everyone. Bye. And we'll be back with another session uh, of evidence to decisions in other month, in the upcoming month. Goodbye. Good night.
Yeah.
Good evening.
Thank you. Thank you all.